In progress.
Okay. Are you ready?
The room is open. Just give it about 30 seconds and we can get started.
Should I just start automatically?
Yep, you can just welcome everybody and get started.
Okay. Okay, we can start. Welcome, everybody. Thank you for attending the first of the annual, monthly AO hand webinar on fractures. And today we are talking about the metacarpal fractures and their complications. My name is Emil Dionysian. I'm a hand surgeon at Southern California Kaiser at Orange County. And we will have several faculty. I'm going to introduce the faculty next. We will have Dr. Yao, Jeffrey Rao, who's from Stanford, California. He's a professor at the Stanford University Medical School. And we'll have Brad Peterson, who is one of my colleagues, hand surgeon at Kaiser, Orange County, California. We will also have the input from Stephanie Kannas, who is a occupational therapist. She's the lead occupational therapist and hand therapist at the Mayo Clinic, Rochester, Minnesota. Some disclosures we have to do. Most of the faculty don't have any financial relationships. Dr. Yao has some, has been expressed on the in the slides that you can see. AO North America staff involved in the webinar have no financial relationship to disclose. And we all acknowledge that there is a educational activity from the foundation, AO Foundation, and they are funding from the Synthes. Just by way of credits, we will get CME credit for this attending this webinar. There's 1 hour of, actually 1.25 hour of AMA approved credit. It can be claimed at the end of the seminar after you receive your evaluation in your email. Then after you finish your evaluation form, and then you can be eligible to receive your credit. There will be a link sent to you in about 24 hours after the conclusion. Just some housekeeping stuff. That AO is a nonprofit surgical specialty and dedicated to improving the patient care with musculoskeletal injuries. The AO does not endorse any or promote any specific product or services or any commercial entity. Equipment used in this course are, you see on the X-ray and on the demonstrations. They're only for teaching purposes only and to enhance our learning experience. So just some Zoom etiquettes. All the microphones have been muted and the videos have been turned off. If you have any questions, we welcome them. Please use the Q&A box for the questions. The moderators and the faculty will review those questions as they come and may answer it either immediately or at the end of the session during the question and answer session. Please use the chat box only for the staff and the faculty communication. This webinar is set up to discuss the anatomy and mechanism of fractures of metacarpals, especially hand metacarpals, their treatment option, and possible complications that may come up. We will also discuss the role of hand therapy and rehabilitation in regards to getting function back either from surgery or from the injury itself. The learning objectives at the end of this presentation, you should know the anatomy of the metacarpals, understand the mechanism of fracture for metacarpal fractures, be familiar with the indications for both operative and non-operative treatment, know the indication for procedures, for what kind of procedures at what situation to be done, and also be familiar with post-injury rehabilitation and therapy that is involved in regaining function of the hand. So here's our agenda. Next, we will go with Dr. Peterson to talk about mechanism of injury and the incidence of fracture and evaluation, and also non-operative treatment. Dr. Yao will take us to operative treatment and options. We will also consider complications after that, and Stephanie Kannas will give us some input about the therapy that's involved and occupational therapy and hand therapy. Around the end, we'll have some case presentation if time allows, and we'll wrap it up at the end with take-home message. Just to get your appetite going, this is a simple case of a 30-year-old who is 3 weeks after a motor vehicle accident with pain and stiffness, just to think about what kind of options we will have in terms of treatment and how we're going to go about it. Hopefully, we'll get the ideas from the lectures. And next will be Dr. Peterson that will be starting. I'm going to stop sharing, and Dr. Peterson can start sharing. Dr. Peterson, you're muted.
Yep, you're muted.
How's that?
That's good.
Great. All right. Is everything coming through now? I see just my screen. So thank you, Emil, for having me. Like Emil said, my
We
name's
are not seeing your presentation. Right.
You're not seeing my presentation?
Nope, we are not.
Okay.
Now we are. Perfect. Just need to go to show mode. Perfect. Thank you.
How's that? Great. Okay. Thank you, Emil. So now I'm unmuted. So thanks for having me. I was having some technical issues with just the Zoom connecting to my computer, but so I'm one of Emil's partner. I'm an orthopedic surgeon in Orange County, and we all at Kaiser in Orange County have a pretty high volume practice. And one thing, whenever I think about metacarpal fractures, when I was and I have no financial conflicts to disclose. Fortunately, most of the time we don't treat metacarpal fractures like this in this X-ray right here. But I remember when I was a resident rotating through, we would sometimes get contacted by the neuropsychiatric institute that was adjacent to our hospital, and there'd be these pleasantly unaware patients that we'd get consulted for a swollen hand, get X-rays, and we see they'd had a metacarpal fracture that had been completely left untreated, but they'd be moving their hand completely normally with no pain and excellent function, where they really had no splinting, no reduction, and really no treatment. It just was not just benign neglect, but complete neglect. And then at the same time, we'd sometimes rotate through a county hospital where patients had been, it was a resident run service there, and they'd been operated on, they had some nice X-rays, but the patients didn't always get to therapy or early motion. A lot of those patients were very stiff. So from that experience, I always had somewhat of a bias towards non-operative treatment for these metacarpal fractures when they're not these high energy open injuries. And I think it's important just to remember the treatment goals for all metacarpal fractures is we want to restore the normal hand motion and strength. Most of the time these patients don't have pain afterwards, but we want to restore as close to as possible a normal appearance and do it quickly and doing it cheaply. The metacarpal anatomy, the metacarpal head it's a cam shape, so it's kind of an ovoid. The radius is of curvature in flexion. When the proximal phalanx flexes down, that radius is longer than when the proximal phalanx is extended. And that was kind of drilled into me as a resident. When you're splinting these patients, we really stressed splinting them in a position of function with the phalanges flexed, as in the MP joints were flexed. That, with more recent studies, that doesn't seem to be quite so important, but it is important to remember somewhat that the metacarpal head is cam-shaped if you have an interarticular fracture that you're trying to reconstruct. Usually the third metacarpal is the longest. The index and middle finger metacarpals are more fixed, and the ring and small fingers are more mobile, and they'll tolerate a little bit more deformity, and with it still resulting in a functional hand. When you do have these fractures of the metacarpal, usually there's the pull of the interossei leads to kind of an apex dorsal angulation. If there is comminution or shortening with each 2 millimeters of shortening of the metacarpal, you'll have a tendency for an extensor lag. Just the shortening of that extensor tendon or the shortening of the bone leads to an extensor lag. That can actually be tolerated fairly well if it's not more than 20 degrees or so of extensor lag, because there is some redundancy in the extensor mechanism's ability to compensate for that shortening of the metacarpal. But that can lead to this pseudoclawing where you get extension of the proximal phalanx, but then the PIP joint tends to flex and you'll get a kind of a pseudoclawing. And that's one thing I think that talking to the patients when you're going to embark on an operative or non-operative treatment for these fractures is really understanding what the patient's expectations are and what their needs are as far as returning to work or their activities and their time course of that. If you have an isolated metacarpal fracture, the intermetacarpal ligaments do fairly well resist a lot of shortening of that if it's just an isolated single metacarpal fracture. Scissoring, when you have a rotational deformity, that is usually very poorly tolerated by patients, and that's something that's going to tend to make the patient and you want to have an operative treatment. And obviously, intra-articular fractures, you have a lower threshold for operating on these patients. And again, we all know that metacarpal fractures are very common. They're probably, hand fractures in general, they're probably a third of all hand fractures. And generally, they heal quite well with just non-operative treatment. Particularly the small finger metacarpal fracture, there have been articles since at least the 90s showing that fifth metacarpal fractures can tolerate significant amounts of apex dorsal angulation and still result in good function, but the numbers range all over from 40 degrees to even 70 degrees or more. But the position of when you're treating these fractures, the position that you want to place the MP joints in, I don't think it does any harm to place the patient's hand in a position of function, but a number of studies have shown that you don't necessarily have to make sure you're in that the MP joints in 70 degrees of flexion. And some patients, I think, do quite well with just buddy taping in early motion. And whether the patient is treated with surgery or with non-operative treatment, I'll warn the patient early on that even when the fracture is healed, just due to the swelling and just some of the altered mechanics, the MP joint's going to have full passive motion, but at first the patient's not going to be able to fully extend at that MP joint. That extensor lag is going to be present, but it usually does resolve after several months usually. So this is just an example of a case I had in the last 5 months or so, just a fracture at work in a 52-year-old machinist, healthy guy with a closed injury. You can see this kind of spiral fracture. And he actually had already gotten an MRI by the time he saw me because of the swelling. And he did have a collateral ligament injury to the long finger, the third MP joint, which I recommend definite non-operative treatment for that injury. But he had no scissoring. And I kind of gave him the choice of, well, you can treat this operatively and it might get you back to work sooner. But like most of these, when I gave him all the pluses and minuses, he elected for we initially did like an ulnar gutter splint, and I kind of saw him about every 3 weeks. And really, he returned to work after about 3 months as a machinist with full motion and a strong hand. And you can kind of see the x-rays here at his last visit. This is at about that 3-month post-op. You can see the callus. You can still see the fracture line, which sometimes is disconcerting to patients, but I always, tell the patients that the x-ray kind of lags behind the clinical picture. And they see as their motion, their motion improves, their pain goes down, and their function returns to normal, which is pretty typical of a lot of metacarpal fractures, as long as you've noticed they don't have that scissoring and they don't have too much shortening. He probably did lose a little bit of length here in these final x-rays compared to the normal fourth metacarpal, but again, a good functional result. And I have to admit that I don't assiduously read the JBJS, but there is just an article in the January 23 about treatments of fractures just like this, operative and non-operative treatment. With the non-operative treatment, you do get a little bit of shortening, but the functional results are pretty comparable when you have these metacarpal fractures, isolated metacarpal fractures. It's a pretty nice randomized prospective study that just came out in January of 2023. And actually, I have I had a little bit of a confusion with what exactly I was going to be starting with the speaking on, but I have a number of cases to go over that just show kind of complex cases and possible treatment options like that. But possibly now we can transition to Dr. Yao talking about operative treatment, and then I can kind of dovetail in with him after he talks about operative treatment, about the complications of metacarpal fractures.
Yeah, that sounds great. Thanks, Brett. Let me, if you don't mind stopping sharing, I'll load up mine.
Yes.
All right. All right. So thank you both for that nice segue. And so I'll focus on the operative management of these very common fractures. As has already been stated, these are very common. There's about 800,000 of these cases annually in the United States. And this is a good epidemiological slide, which shows that the majority of these metacarpal fractures are in the border digits, or the thumb and the small finger. The central digits tend to be less common, mostly because the thumb and the small finger are out in space and they kind of get caught on things, and that's how these are most commonly fractured. As we've just learned, close treatment is a very useful and viable treatment for the majority of these fractures. It's important to remember that close reduction is rarely successful in holding reduction, but often we're able to accept a significant amount of displacement and angulation. Rotation, however, is less well tolerated, and so those are if there's any malrotation, generally those are treated surgically. We've already learned about casting and immobilization, so I won't belabor this point, but again, it's very useful, and as was already previously stated, I think buddy straps can be often very effective as well, because they allow range of motion depending on the severity of the comminution. So this is what's poorly tolerated. When you have malrotation, this is not something that's going to heal well unless it's reduced and or stabilized. And for me, that's an indication for surgery. On the other hand, you can have some pretty bad displacement, some comminution, and if you look at this x-ray, it looks pretty bad, but the patient had a very good functional outcome despite non-surgical management. So displacement, angulation, both pretty well tolerated. It's just malrotation that's not well tolerated. So for me, indications for surgery are malrotation, any fractures that are displaced, multiple metacarpal fractures, if they're open, and questionably if you have an athlete, particularly if they're in season. I think it goes without saying that clinical objectives for metacarpal fractures are to achieve stable fixation to allow active range of motion as soon as possible to prevent complications such as stiffness, as we just heard. And there are a number of different things in our toolbox that we can use to try to help surgically treat these fractures, as simple as K-wires, interosseous wires, tension bands, plates and screws, I should say, lag screws alone, and external fixation. K-wires can be done for particularly any fracture, except probably transverse fractures. They can be, they're low cost, minimally invasive. The only downside is that the patient's generally immobile while the K-wires are left in. Tension bands, particularly if you have an open fracture, can be very useful because it's low amount of metal. So the implant burden is quite low, and the soft tissue stripping is quite low, and you get very strong fixation. But it's rarely in my practice, my treatment of choice for standalone closed fractures. K-wires, they do have a complication rate, unfortunately, infection and loosening due to lack of stable fixation, and these have to be removed, and the patient can't move while the K-wires are in most of the time. They also have the lowest bending strength, and so this requires protective range of motion. In my practice, I usually still immobilize my patients for about 3 weeks to 4 weeks after while the K-wires are in. What about lag screws? These are very useful for long oblique or even spiral oblique fractures. Can't be done for transverse fractures. Remember, good AO technique. You want your fracture length twice the bone width. 2 to 3 lag screws is usually sufficient. 2 or 2.4 millimeter, depending on the size of the metacarpal. If you have a transverse fracture or a comminuted fracture, lag screws or K-wires are not ideal, and that traditionally would be treated with plate fixation. And it's very stable, as we know, but the trade-off is there's a lot of soft tissue stripping involved when we have to put on metal plates with screws. So again, there's rigid fixation, allows for early range of motion, but the disadvantages are the soft tissue stripping and the potential for extensor tendon adhesions, which may ultimately require tenolysis. It's been published to be up to a 32% complication rate with the plate and screws, usually with stiffness, usually with extensor tendon adhesions. There's a non-trivial average time lost from work. It's slightly technically demanding, but generally these are used for more technically demanding fractures, so that's not necessarily a fair comparison. And often there's a up to 32% revision rate due to hardware complications, either hardware pain from the hardware or extensor tendon adhesions or some combination thereof. External fixation in my practice really is limited to the contaminated wound, open wound, where we're just getting skeletal stabilization while we're getting soft tissue coverage arranged. Otherwise, for standalone, straightforward metacarpal fractures, I rarely use external fixation. The latest thing on that's getting a lot of traction and a lot of attention is the use of intramedullary screws. In my opinion, this is a perfect indication where we have multiple metacarpal fractures, transverse fracture pattern. You could see someone tried to use one K-wire here. This patient was transferred to me and with this pattern. And you can see that with one K-wire, there's very little stability. So we went in and revised it. You could see there are proximal phalangeal fractures as well, which we pinned. But we revised these fractures and treated all of them with intramedullary screw fixation. Historically, the way we would treat this is with 2 longitudinal incisions and 4 plates, which would be a recipe for a really stiff hand and fingers. And with these intramedullary screws, we have a small soft tissue dissection, very little soft tissue disruption, and therefore much better healing. The thought is that we've been using intramedullary implants for tibias, femurs, other long bones, humerus for a long time. And so why not use these in the metacarpals as well? And this is Chai Mugdal from Mass General, who initially published on this technique in 2010 using this Synthes 3.0 millimeter screw here for this metacarpal neck fracture, which typically would otherwise be treated with K-wires, eliminating the benefit of having stable fixation along the adjacent ring finger metacarpal. So now having internally fixed both fractures, he could allow this patient to move immediately. The common question that comes up is, well, is this a problem to put something through the articular surface of the metacarpal head? Well, if you remember, when we fix scaphoids or the proximal phalanx or even the knee for a tibial nail, we're going through articular cartilage, and the morbidity of that is relatively low. So I don't think there's any documented complications of MCP arthritis after intramedullary screw fixation as of yet. And this is further reinforced by some of the work by Rushman and others, which showed that if you insert whatever implant you're using in the dorsal 1/3 of the metacarpal head, the base of the proximal phalanx rarely, if ever, articulates with that portion of the metacarpal. Really, it's when the digit is in complete hyperextension, when that proximal phalangeal base will interact with that portion of the cartilage, and that's rarely the case. So as long as it's in the dorsal 1/3 of the metacarpal head, it's really quite safe. So the way this is done was make a small incision over the MCP joint. You can also do this percutaneously, although I like to make an incision, identify the central central tendon. I like to put my guide wire for whatever implant you would like to use, any cannulated headless compression screw, through the extensor tendon, through the capsule of the MCP joint, and then into the dorsal 1/3 of the metacarpal head. Now, historically, I would actually incise through the tendon, incise through the capsule, and visualize the metacarpal head, but I don't think that's necessary. I think you could just put it right through the center of the tendon and you should be fine. Once the guide wire is introduced in the center position, again, in the dorsal 1/3 of the metacarpal across the fracture site, often you'll use a bone reduction clamp to secure your reduction, and then place the guide wire down, much like you would a femur, for example, and then check it on both the PA and lateral views. Make sure that your guide wire is safely within the canal. Then you can identify the length of the screw, drill it, and then insert the screw. Very similar to any other intramedullary long bone that you would place an intramedullary device in. Typically, the size of the implants for ring fingers, remember, it's the smallest metacarpal. So usually a 3.5 millimeter implant is sufficient there. The index long, thumb, and small can be anywhere from 3.5 to even, I've even used 5 for a thumb. But so any implant that satisfies those diameters or dimensions would be sufficient. And as you're inserting the screw, remember there's a torque and a rotation, so you want to make sure that your digit does not malrotate as you're inserting your implant. And so while it's being placed, just make sure you hold your digit reduced. Now, this is again not a there's no locking screws, so there's no rotational control here, but typically with a good isthmus fit, this has adequate stability. And remember, the difference between the metacarpals and all other long bones, such as the femur and the humerus, the tibia, is that you have an adjacent bone next to it with intermetacarpal ligaments that help hold the correct rotation. So you don't need derotational stability. Now, that being said, there are some companies who are working on putting a derotational component to their implants, but I think that's probably overkill. Postoperatively, if you compare this intramedullary screw versus Platen screws versus K-wires, with the intramedullary screw, we start allowing our patients move almost immediately. Whereas with the Platen screws, you have to wait for soft tissue rest, usually about a week, and then you can start therapy. And furthermore, with K-wires, unfortunately, those patients are immobilized for anywhere from 3 to 4 weeks. Can't move at all, and then start. So they're definitely a little bit behind and at risk of extensor tendon adhesions. There are a number of studies that have promoted this technique in the literature with excellent outcomes. As you can see, here's one of the studies by Michael Garcia and colleagues. And then another study by Ruschelman, who also did that other biomechanical study that we spoke about earlier, again, with good outcomes. Now, there are some caveats to this technique. I would definitely recommend this for transverse fracture and short oblique fractures. For spiral oblique fractures with the large butterfly fragment, sometimes it's difficult to gain adequate purchase in that fragment, and you may want to try with a clamp to clamp it down and then insert your implant, but I would have a lower threshold to treat that with lag screws. And certainly if it's accommoded through the neck area, you worry about collapse of your fracture if you just have the one intramedullary screw. So those are kind of my caveats to the technique. Again, some more studies showing the benefits of the intramedullary fixation. So in summary, my operative treatments for metacarpal fractures, again, K-wires are the workhorse. They're fast and easy, inexpensive, and less foreign body load. The disadvantage being not rigid fixation, requires prolonged immobilization. So these patients are sitting around in a splintery cast for up to 4 weeks, and then they start therapy. So they're a little bit behind. But again, it's very it's stood the test of time and still very effective. Tension band, again, in my practice, is usually more for open injuries. Plates, typically for multiple fractures, particularly transverse fractures, particularly if someone is an athlete who needs immediate stability and get back to activity ASAP. The downside, again, being the periostral stripping, which may devascularize your fragments and a larger foreign body load, and that can lead to eccentric tendon adhesions as well. Lag screws are very useful for oblique fractures and spiral oblique fractures, not for transverse fractures, but it's kind of very similar to plates in that it requires a relatively large soft tissue dissection to get the appropriate reduction and placement of your screws. External fixation in my practice is really only for open contaminated injuries. And lastly, I added the IM nail screw, which again, I think is becoming more and more mainstream. I think this is very useful. It's very fast, easy, and strong. Good for multiple metacarpal fractures. Very little soft tissue stripping. The only potential downside is the cost is more than most of these other constructs, other than the plate and screw construct. So with that, I'd like to thank you. Happy to take any questions in the Q&A, and I think I'm going to pass it back over to Dr. Peterson, I think.
Yeah, Dr. Peterson can follow. So if you stop sharing, and Dr. Peterson can share back.
Yeah, I think I'm done sharing.
Jeff, this is Jay Bridgman, one of the other AO faculty, while Dr. Peterson's getting set up. I just had a question on the intramedullary screws. Do you ever find that intramedullary canal is too small, or how do you manage that technically, intramedullary screw choice versus canal size?
Yeah, great question. I have not, knock on wood, but that is something that always worries me. I just remember from when I was a resident in rotting femurs, and you try to put your implant down and it gets stuck at the isthmus, and there's nothing more stressful than that happening. And so I never want to endure that in the metacarpal. Preoperatively, you can template out your medullary canal by using whatever imaging software you have, or even a ruler to measure the dimension of your isthmus. Obviously, the isthmus is the most important dimension you want to measure. The ring finger is always the smallest, and usually a 3.5 millimeter will work, or you can always go down to a 3.0 millimeter. It depends on whatever system you use. Make sure you have multiple options available to you. One other option is that you can even just put the implant on the skin, get an x-ray, make sure that it looks like it'll fit through the isthmus. So there's a number of ways that you can do it preoperatively. And then before you drill, now let's say you're starting the implant down and it is getting stuck. A couple options, just kind of like with when you're reaming for a femur, you just pass it down, back it up, clean the flutes, pass it down, back it up, and then slowly it'll generally pass. I haven't run into a single metacarpal where I haven't been able to get an implant down.
Do you ever ream the canal?
It's interesting. There is a drill, well, whatever system you use, there are drills that you can use. I typically don't, because I don't want to take out all that cancellous bone. So I usually just use a pilot drill and just drill the hole, just like with a scaphoid, just get the hole started. And then I put the implant down, preserving as much cancellous bone as possible to sort of stimulate the healing. So I don't ream all the way through the isthmus.
Okay, well, I'm sure there are going to be more questions to discuss at the question and answer session. I guess we can follow with Dr. Peterson on the more of the complications on metacarpal fractures.
Great. Well, thank you, Jeff. And yes, so I have kind of a series of cases, but each one has like a little like theme to it that has a point about the complications in treating these metacarpal fractures. And the slide I was playing with before this is there was a kind of a master surgeon named Bernhard Weber, like after the Weber A, B, and C ankle fractures, but he had a principle that he called his mini-max principle, where it was just the idea when you're treating any fracture, you want to do the minimal amount of invasiveness with the maximum amount of stability and really maximal resulting function for the patient. So this is, a common injury where you have a couple metacarpal fractures, fairly displaced. And like Jeff had been describing, you could treat this. You probably wouldn't want to do K-wires just because they're rather transverse fractures, but plating, you wouldn't want to do just lag screws, but you could treat these with K-wires. You'd have to immobilize. You could do plates, which would be pretty classically what I would do in the past, or the metacarpal nails. And Jeff talked about those. But, and this slide just shows that you have these different sizes, and you can pick a metacarpal nail that fits the intramedullary canal, allows the person to start an early range of motion protocol. But again, that Minimax principle, it's not just making a small incision and picking an expensive implant. It's carefully considering what the patient needs and what can I do to get them to function back as quickly and simply as possible. And consider what are the costs of the patient when you operate on them, when you don't operate on them, and then having a discussion with them. And so for this example right here, this was a patient I had a couple of years ago, and she'd actually been walking her pet Chihuahua, and she was attacked by her brother's pit bull, and then her brother was trying to break up the fight and accidentally hit her. And it ended up being an open fracture with a laceration of her extensor tendons, but it was a totally unintended injury. I took her to surgery that night. She came in with an open fracture, and I did just the plates available. This is kind of the old fashioned little blade plate, and I didn't even put a splint on her and got her moving right away. And this, you could say, it's a big plate and kind of an injury with an extensor tendon laceration, but she was actually very involved with her therapy from early, or very motivated with their therapy early on, and she actually had a very quick, excellent result. Whereas another patient here, kind of a similar injury, this was from a car accident where she'd been rear-ended. So it was a closed injury, her airbag went off and broke her hand. Just an isolated second metacarpal fracture. This is a fairly small amount of dissection to get in there. You're really not that close to the extensor tendon. In this case, there was no extensor tendon laceration, just a closed injury. I did a standard plating, maybe a fairly small plate. She did form some callus, but for whatever reason, this lady actually did end up with stiffness. Even though there wasn't an extended period of immobilization, she went to therapy. But I think a lot of the trauma of her injury and just some social factors, she ended up having quite a bit of stiffness at that MP joint. And while those cases, kind of similar looking injuries, the first one I'd say is probably a worse injury, but the second one ends up being having more stiffness. This patient here is another example of just a metacarpal fracture, a common injury. And sorry, on my screen, I'm not seeing my full screen here, but this was a boxer's fracture that was treated appropriately, but the 16-year-old and his mom didn't really like the loss of the knuckle prominence, and they came to see me at about 8 weeks, post-injury, and didn't like the deformity. They felt pain in the palm, and he didn't like the look of his X-ray. And I think in the past, this was kind of a hard fix. If you said, well, you can live with this, but if they want some surgery, plating this, doing cross K-wires, all those techniques anything can lead to stiffness. But I thought the metacarpal implants or the metacarpal nails would be a possible good solution for this, to correct this fairly significant angulation. And so make an incision, take down the callus, and then put that metacarpal screw in there that actually does allow you, again, to correct a deformity when you've had a boxer's fracture that the patient is not accepting of their malunion. Another case here, this is an intra-articular fracture where this guy's an avid boxer, and he has this pretty common intra-articular fracture. It's displaced in the different views. And so obviously operative treatment, but I was, told him I was thinking he's going to get pretty stiff, and I probably would do some sort of plate technique, but there was a lot of comminution there. And so I put in this X-ray on the left, just shows a plate with actually a K-wire just to stabilize that headpiece. And I removed that K-wire after about 2 weeks, but I did splint this person. And this gentleman actually ended up having no stiffness whatsoever. This was a couple of years old case. He still hasn't had the plate removed. In this case, this patient here, it was a mountain biking injury, less comminuted, less intra-articular, and he is also a very motivated, healthy patient. You can see the displacement of the injury. Definitely was going to do operative treatment for it. And I used that metacarpal nail, and he went on to a nice union, but he also became fairly stiff afterwards compared to the first patient with the plate and K-wire at a longer period of mobilization. So early mobilization is obviously very important, and avoiding plates and screws is probably going to, in general, lead to less adhesions and stiffness, but it's not always a guarantee that you are going to get the stiffness with the plate, or that you won't get it with the intramedullary nail. Here's a case here with an older gentleman in his 90s, multiple medical problems. He actually had this injury and had been seen in an urgent care clinic, supposedly with a closed injury. But when he came to my clinic, he had this picture in his this is what his hand looked like. You know, they put steri-strips on there. He has a couple-day-old, probably open fracture. So in this case, with this infection, I thought the best thing to do with this, he was not well cared for at home. If you look at this picture too, he has a little bit of deviation of the finger. He did have scissoring. I actually took him from clinic to the OR that night for a washout, and then the next day after the washout, then actually plated him. And a lot of these older patients, if you do operative treatment, they actually, if they can tolerate the anesthesia, they can do quite well with the plate and screws, and he goes on to a good functional result. In this case, this was a 4-week-old gentleman, a 4-week-old injury in a gentleman that had been actually shot by the police. He'd been in an altercation with his neighbor, and so the police got involved, and he had actually had an injury to his hand and also his leg. He'd been in jail, and then he came to me about 4 weeks out. So he has this injury that's with bone loss, pretty high energy injury, but the rest of his neurovascular exam was actually intact. And so in this case, I think dealing with bone loss and also the potential for, restoring that anatomy is kind of difficult. In general, with cases where I'm going to have to restore length, I like to use some sort of distractor to assist. This is actually a distal radius fracture, but just for the next couple of slides, it's just to show what I was thinking, why I was putting a distractor on a metacarpal. But when you have a distractor there, it allows you to stretch out the joint or the bone, and then at your leisure, restore the articular surface, or actually put a greater force across the bone to regain your length. There's just some more pictures of that distractor assisted reduction. So in this case here with that case with the bone loss from the gunshot injury, I have here the slide on the left is just the distractor. One of the Chance pins is through the plate, so it doesn't rip through the metacarpal head. The more proximal pin is in the capitate, and then I can regain some length until the soft tissues are under too much tension. And then with the small vibrouge, bring the plate down to the bone and put in the screws. And then you can see, and then I used, actually in this case, I really, he was not the most compliant patient. I used iliac crest bone graft, packed that in there. And I definitely didn't restore all his length, but, we end up goes on to a union with that. When you are using those metacarpal nails, I've always been kind of worried what happens when they fail. How do you take them out? And this is a patient that had an injury like this with the 4th metacarpal shaft fracture and the 5th CMC dislocation that was treated with a nail and pinning. He went on to heal this, but then he got in a fight and he came back with the broken metacarpal nail. So going through dorsally and put a retrograde K-wire actually antegrade K-wire through the distal portion of the nail, and then take the nail out distally, and then through that fracture site, take the proximal portion of the nail out, and then do a revision with the plating. And then finally, with complex injuries, sometimes you have a combination of, bone loss in the joints, in the and also the soft tissue injury. This patient actually had his radial artery or digital artery and nerve to the index finger were out, and mostly it was an extensor tendon injury. All the flexors were actually intact. So with this X-ray, I was pretty concerned. What could I do with any of this? And I warned the family about how possibly having to amputate the index finger. If you look on this picture here on that fourth metacarpal head, it's a very distal fracture where the saw had actually cut through basically the metacarpal neck of the fourth one, but that was the only one I actually could fix. I actually used the metacarpal nail for the fourth, and all the rest, the reconstruction was with just some PMMA with the plans of doing an arthroplasty for the third metacarpal head, and then a fusion of the second to the proximal phalanx. And that's just the post-op X-ray there over in the lower corner, or at the end of the case. And he's been around in my practice for a year and a half. He obviously has a stiff hand, but he still hasn't elected to, he's functioning pretty well. He's actually hasn't gone for the operation to do the MP arthroplasty or the index finger fusion yet. He's functioning actually quite well. And so when Emil had said, "Oh, will you talk about metacarpal fractures and what then their complications?" The main thing that I deal with is just infections are possible and they happen, but they're pretty rare and they're usually fairly easily treated. Non-unions are incredibly rare. Some people have pain, but the biggest problem I deal with is, the stiffness and tendon adhesions, and I try to organize them according to the nature of the injury, the patient factors, and then what things I can control. But again, I guess that'll be part of the discussion for this group and with hand therapy is just how do we deal with stiffness after these metacarpal fractures, and that's yeah.
This is great. So this is a good segue into bringing Stephanie Kannas, who's an expert in hand therapy. So she can give us her points of what magic she has in her hands to help us decrease the chance of stiffness and other complications after surgery or just a regular fracture. So Stephanie, it's all you. Thank you.
Thank you for having me tonight. It's my pleasure to talk on therapy after metacarpal fractures, and Dr. Peterson and Dr. Yao already sort of really stated the main problems for therapists. It's stiffness of that MCP, getting that composite fist back, and then the gliding of the EDC because it's tethered down into scar tissue. So we will keep moving forward. So what I want to talk a little bit about is the anatomy considerations that the hand therapist takes into developing our treatment plan. How surgical fixation also affects when I can start therapy. And then I have a really complicated therapy case that I wanted to share with you all, that things don't always go the way you want them to do, and you have to have lots of tools in your tool belt to be creative. So first we'll go into anatomy considerations. The location of the fracture matters to me, whether it's at the neck, the shaft, or the base of the metacarpal. A lot of times that can determine if I'm going to make a hand-based splint versus a forearm-based splint. Do I want that MCP joint position in flexion or extension? And we'll go into a little bit more about the literature. That probably doesn't matter as much these days, but also if it's at the base, I could maybe potentially leave that metacarpal free. Or if it's a really non-displaced fracture, maybe doing somebody strapping as well. And then really understanding what forces may help deform the fracture or be more likely for a displacement. And so those are things that I all want to look at in getting that EDC to glide. So as we look into this, when I look at a metacarpal neck or head fracture, I'm really thinking as a therapist, my deforming forces are the intrinsic muscles. Most likely, I want to have a hand-based gutter type splint, whether it's radial based or ulnar based. And I'm going to go ahead and I'm going to look at, do I want that MCP inflection versus extension? There's been several studies out there listed down below, one by Harris, Beckenbaugh, Netter, and Rizzo, and then Hofmeister, Kim, and Shin, and then Tavalitzi, Ruland, and Hogan. And with those, the outcomes don't really matter. You're not necessarily going to get more stiffness because I chose to splint something in extension. What I learned from Dr. Beckenbaugh was he preferred to splint some of his metacarpal neck fractures more in an extension because he wanted to make sure that the bone had good alignment. And so that was one of the various things that I learned from him is sometimes you have to do the opposite of what you think is that safe position because he wants that good alignment of that fracture. Scar management is really important, especially if there was any type of open reduction, internal fixation, or even like a closed reduction with percutaneous pinning. Scar management matters on the back of that hand. And then active range of motion, as soon as I can, I need to get that EDC gliding. And I need to keep those intrinsic stretched. So doing a lot of intrinsic minus position will really help as well. And then doing a lot of gliding of that EDC so it doesn't get tethered down into the scar tissue formation. The metacarpal shaft fracture is a little more forgiving for the hand therapist. Still, my deforming forces that I look at are the intrinsics. This is really where I could go with a hand-based splint versus a forearm-based splint. And considering I might want to put the MCPs down into a little bit more flexion, maybe just to give them a head start. Scar management again and EDC excursion. Those are really my important things, and that's my theme as we continue to move forward. The base fracture is one of those as well, where to me it's the intrinsics that could be a deforming force down there. That's the time where I'm probably going to want to make sure I have the wrist included in my splint. And I may put the MCPs in the splint and I may not. It has more to do with patient compliance. Do I think they're going to do too much? I might include more. If I think they're going to be behaving, I'm going to put less in. So these are some of those things that while I'm first meeting the patient, I'm sort of individually sizing them up. Are they adherent? Are they not? And sometimes it's good to have that discussion with the surgeon. Did they comply with all your recommendations from the time you met them to the time you sent them to hand therapy? That can help guide some of my treatment as well. Also, scar management is really important, especially if there was any type of hardware fixation. So moving into surgical fixation types is really you could do a closed reduction, no type of fixation. The downfall for that is as a therapist, there's a longer delay in me beginning to develop range of motion and tendon gliding. With that, that's going to be harder for me to get that composite fist back. And then we go into K-wire fixation. A lot of times, as Dr. Yao and Dr. Peterson have already alluded to, we're going to hold a K-wire longer and maybe do protected motion, but we're going to hold them for several weeks because the K-wire itself isn't stable enough to stand the force of motion. When you're looking into plating, again, that is where if that fracture is absolutely stable with that plate in place, send them to therapy as soon as possible. We need to get that EDC gliding. And this is often where our problems are with scar adhesions and tethering of that EDC. And then again, you have the IM, intermedullary nails. Again, if it's absolutely stable, send them to therapy early. We want to get them moving. We still have to look at scar adhesions to make sure that we can continually get them moving. From there, I want to show you this case that we have. So this is a 40-year-old gentleman that came to our clinic. They were at their family farm helping the family, and a seed pellet from a forklift crushed a hand. So as you can see, we have an open fracture of the second and third metacarpals and possibly contaminated. So they came to our facility from an outside facility. At the outside facility, they did an irrigation and debridement. Came to our facility, they did an irrigation debridement. They also put all these fancy K-wires in. This gentleman, back at an end of April, about 12 days later, they came to hand therapy. They were given a forearm-based splint with the eyepiece free. So we sort of made it more like this. We just included the index and the long finger. We left the ring and small free because we wanted to get things moving. This gentleman, unfortunately, had a lot of swelling. He was very stiff in all of his joints. And one of the reasons was he was petrified to move. He didn't want to do anything to screw up his hand because his job, besides working with his family on the family farm, was he was a commercial airline pilot. He needed his hand to get back to his job and his passion. So he started coming into therapy twice weekly. He would drive a long distance to come see us at my institution, and we worked on unaffected range of motion of all of the joints of the hand, except for the index and long finger MCPs. We also had to do a lot of education and counseling that it was okay to move. We weren't going to hurt the fractures. And it took a lot of reassurance. If we gave him another therapist for a day because his primary therapist was off, we had to introduce that therapist to him and sort of like build this rapport prior to even seeing him, just because he was that apprehensive about moving. And this was also those times where I'm fortunate to work with the surgeons right across the hallway from me. I would bring their mid-level provider in, and I would sometimes bring the surgeon in just to give him reassurance that everything we were doing was not hurting him. As we kept moving along, his original injury was at the end of April. He continued to have buried hardware still in August. And as you can see in this image, now his buried hardware is beginning to be exposed. You can appreciate his scar. It is tethered down. His edema still isn't resolved that well. And so we were doing multiple things with scar management. We were doing various massages. We were doing elastic taping. And we were being as aggressive as we could be with all of his joints, except for the index and long MCP joint, because he was failing to make bone. And so I sort of wanted, before I show you those next images, I want to go over with all of you. Sometimes you're going to maybe read your therapist notes and they seem a little strange. One of the things we can do to help with the muscles and the tendons is do something called instrument-assisted soft tissue mobilization. So you think about that EDC and where it originates at the medial epicondyle. I want to try and keep that muscle at full length so they can get that composite fist back, and it's not because of a soft tissue structure. So this is one of those things we can do up into the forearm. We can also do this to help loosen scar adhesions down in the hand. As we move forward, another thing that can work for some individuals, it doesn't work for everyone, is using elastic taping. I like to use this little basket weave or X pattern, and that can really help loosen those adhesions on the back of the hand. You may have also heard people are now beginning to do a lot more cupping. Those types of things, or anything with a negative suction to help try and lift that scar tissue up and get that EDC to glide. Unfortunately, this gentleman had a lot of delayed healing. His fractures weren't doing so well. And so the surgeons decided to put a nice little plate into the index finger itself, and we converted that to a plate fixation. After that, we had him do some aggressive EDC gliding, And if you haven't seen this before, I typically have them hold on to a highlighter or a pen, and I'm going to have them go between a full composite hook and up into intrinsic minus position. That's a really nice maneuver to make sure that EDC is free from any tethered scarring. With this is his outcomes 2.5 years later. I apologize for the fast forwarding, but if you look on the right-hand side, you can see he never did regain full MCP flexion of that index finger. It was still quite stiff, and his finger stood up like this. But from a functional standpoint, this outcome didn't limit him from returning to helping on the farm and returning to being a commercial airline pilot. So what I want everyone to know, location matters for orthotic fabrication. Your therapists are going to want to glide that EDC as soon as possible. We want to avoid any extrinsic extensor tightness, and aggressive scar management is the key to get that full functional motion of that hand back, in my opinion.
Okay, that's great. That was awesome. Actually, while you're on, I have some questions to ask about when you mobilize it. Do you have any preference at what angle you make your splint on? Is straight, bent, anything in between?
So I sort of go with surgeon preference. I work with quite a few surgeons at my facility. So a lot of them, again, work on what's best for the fracture to keep it in well alignment. And so there are some articles out there talking about techniques for reducing fractures where you actually do some distraction on that metacarpal head, and then you put them into a 3-point splint design. So that's one thing we do when the surgeons specifically ask for that position. But most of the time, I'm still getting them down into some type of intrinsic plus position. Rarely do I ever get them down into a full 70. I'm pretty happy if I get them into a 40, if that's all they can tolerate from a pain perspective.
And another question always comes up, what kind of modalities do you use? You think it's any heat or cold or anything in combination to get things moving?
So I really like heat more than cold. I would probably do more of a hot pack or paraffin if I needed to help elongate tissues. I am not as big of an ultrasound fan anymore. I do use it occasionally for scar management if there's a really adhered scar and tendon. But I'm starting to use more of those other tools that I showed in the videos, doing more soft tissue work with instruments and then using elastic tape and cupping to help me get the results that I want.
And there's one more other question. You said something about the patient forming scar and the type of scars, and there are different patients make different kind of scars. Some people are loose, some are very tight. How do you judge in terms of is a scar former and non-scar former, and how aggressive to be?
Oh, that's a good question. Yeah, so I'm going to try and show on my back of my hand. So if I can sort of take, especially on a metacarpal, if I can go ahead and lift the skin and do pill rolling, I would say, oh, they have a really loose scar. But if I pinch and their skin doesn't come up, I call it into the mountaintop, but instead it goes deep down into a valley, and it's that entire length of the incision. That is someone I'm going to be super aggressive with my scar management, because at some point I feel like that EDC is going to be tethered in that scar, and we're going to have limited motion.
That's a very good point. That I like that technique. I'm going to use that for my patients.
Your patients may not like you if you lift their scars, because it can be pretty painful. So make sure they're sitting so they don't pass out.
But do you do it around the injury or anywhere else?
No, I do it right on the scar.
Okay. Jeff, do you want to present that complication case that you had?
Sure. Since it seems that we're all well versed in the intramedullary nail fixation, I want to show that it's not necessarily the panacea. So let me share my screen here. This is one of my patients, of course, an anesthesiologist who works with us. So someone I see all the time. And so he had a bike crash. And you can see he has a small finger metacarpal fracture and an index metacarpal fracture is relatively comminuted. So what do you folks think? How would you address these fractures?
Boy, that's a number one, it's a colleague. So that's already a lot of pressure. And two, is there scissoring any problem with the motion of the fingers?
The small finger's fine. The index finger, there's some malrotation and some shortening, as you can appreciate on the X-ray. Yeah. And he's an anesthesiologist. He just took a sabbatical previously, so now he's back in the work pool, and he doesn't want to. He wants to minimize the amount of time that he's out.
So I can see, if it was just a small finger, we could just leave it alone. But obviously, with the index finger, especially with a little malrotation, it may require some surgical attention. What do you think, Brett?
Yeah, I think just the shortening of that index finger, and it doesn't tolerate it well. So you're definitely saying, an operative treatment, and I really do like the intramedullary nails, because I think they are, it's a low profile implant, less chance of stiffness. But the main thing, especially if it's one of my colleagues, I'm going to get a nice looking X-ray, because that's what I was trying to say in my complications thing is it's hard to predict who is going to get that stiffness. And so, but just seeing that I would operate, and again, 5 or more years ago, it would have been, I think I would have plated, and now I would tend to do metacarpal nails.
So perfect. Stephanie, if you get this patient decides not to have surgery and would like to get as fast as possible to get back to work, how would you approach it?
I think I would go ahead and clarify with the surgeon, especially if it's non-op. I would like to really make a hand-based radial gutter, probably put the MP down maybe in slight flexion or comfortable flexion, get those IPs moving right away, get that wrist gliding right away so I can get some proximal glide out of that EDC. I probably would clarify with the surgeon if they wanted buddy tapes, but I would try and start doing gentle, pain-free, active range of motion, and then have them come out of the splint 4 to 5 times a day to do that. If there was any swelling, I'd do some type of compression.
But you said the radial gutter, but she also has a fracture of the little finger. So
that would be probably where I would put then. I'd either do a radial gutter, putting them all in, or I would do an ulnar gutter, putting them all in. I guess I would give the patient that choice.
Yeah. Okay. All right. So Jeff, what do you decide to do?
So those are all great points. Thank you for those points. So just a question for Brett. So you mentioned that you'd go with the intramedullary fixation. Is there any contraindication in your mind for doing an intramedullary?
Sure. One thing is, like here, that metacarpal head on that second one, it's like you say, it's comminuted, is going to split open. So that's what I wouldn't tell them from the beginning, like, oh, I'm definitely going to do a metacarpal nail, and I'd obviously have my little modular handset there, but I'd want to see, are there any like sagittal splits in that second metacarpal head that would prevent me from kind of doing an intramedullary nail. And obviously on that fifth metacarpal, I think it's since I was there, and I'd be like, I would not, if I'm going to operate on this person, I want to leave the OR with just a soft dressing. And so I would, would look at that fifth one. I probably would plate that.
Oh, plate the fifth. Okay.
Yeah. I mean, you could do like it, depending on lag screws. It just depends on like, but I like those like 1.5 or very small plates, and I just like that little buttress effect, and it makes me more confident. But you could lag screw too, obviously.
What about an IM nail for that one?
Oh no, my first choice for both of these would be with this an anesthesiologist, wanting to go back to work. I'd be like, let's put intramedullary nails in both of them, and then a soft dressing and get you back to work as soon as possible. Just with the caveat, are there any in the second metacarpal head? Where is that split?
Yeah. So, okay. So great. So from a technical standpoint, let's say you're in the operating room, how do you make that decision between cracking open the small frag set or cracking open the intramedullary, the cannulated screw set?
Sure. So like in a case like this, I'd be in the OR and I probably would have the patient either general anesthesia or sedated with MAC, and then I actually on all these I pre-inject with lidocaine with epinephrine. Then I examine them with a mini C-arm, and I just see what kind of a reduction can I get closed. This is obviously a pretty acute injury. It's going to move, and again, that fifth metacarpal, it's kind of a dealer's choice. But the second one would be if it looked like, oh, there's, let's say, enough. I kind of eyeball it with, is there enough proximal fixation for that screw to get in that head? And I would kind of cheat to make it it's shifting over ulnarly. So I would cheat my screw, my metacarpal nail, a little bit more radially, I would see how it lines up, and then I'd probably put it. I would put the nail actually on the ulnar side to buttress, so it doesn't shift like that. I'd want to correct that little that oblique from the oblique fracture, the shortening and the shifting. So I put the nail, I guess, more ulnarly. Yeah, that's a great point. That's a great point that you bring up. So, and then what size implant would you plan on using for this? Probably, they have the two sizes. I think it's the 3.6 and the 4.5. I'd probably, the 4.5 in general, except for the fourth metacarpal, usually is the larger nail tends to be the one I use. And especially in a male, he's probably going to, you have both available, obviously. Yeah. And okay. But probably the larger nail. Great. All great points. So let's see. This is what I did. Mm-hmm. I got nervous with the isthmus on the index. Sure. And so very good points that you brought up. So I did put intramedullary nails into both. I don't know if I could have gotten the 4.5 into the index. That doesn't look like it. Looks like it needed the 3.6. Yeah. And so would you have done anything differently here? The one thing is with these, I will sometimes if it's that oblique fracture, I will put a little, make like a little stab incision and put like the little, I'm like a wannabe traumatologist. So I like those little, I copy what the traumatologists are copying us with all their mini plates these days. So I kind of copy them, and I'll put like little stab incisions and use like a little point of reduction tenaculum and get like a totally hold that reduction, then flex that down. And like you actually do I know a lot of people that do totally percutaneous with their retrograde K-wire for the guide pin for the nail. I'll usually make a small little incision, then I can get my perfect starting point. But that's the only thing is I'll get that I'll put a little point of reduction tenaculum across to hold the reduction as I put the retrograde nail in. Isn't that one of the kind of relative contraindications for this kind of nail is that this high oblique fractures? Because you don't get the nice locking, and if you're twisting, you even malreduce it right to trying to put it in. So it's a large as a push to try to do this kind of a short oblique, but a long oblique, it's kind of tough problem. It's tough. Great points. You're prophetic there. So this is at this stage of my career where I was trying to just kind of push the envelope and see. Mm-hmm. If there was a limit, and because it wasn't really well in my mind delineated where the indications end for this implant, but I felt pretty good about this. And to Brett's point, I did use a bone reduction clamp to hold that reduced. This is after I'd done everything and pulled the clamp off. But again, to Brett's point, I think if I were to critically look at this, the implant is going through the radial side of the head rather than the ulnar side, as he just said, where the bone is more stout and would prevent that further shifting. And so, in fact, 4 weeks post-op, lo and behold, this is what we're dealing with. So, what would you do at this stage, guys? Sure.
Well, the options are just take off the hardware, obviously, because it's sticking up. It won't problem with the range of motion and extension of the finger. And at 4 weeks, there's semi-healed. So we'll see how much motion is there and how much range of motion is there, and if we can just leave it be. If there's any rotational problem, then you need to take down the healing and do a plate and correct it. Is there any rotational problem?
Yeah, so thankfully we were able to correct the rotation during the case, but clearly we lost the reduction in there was some subsidence of the fragment. So he lost height. And so I did exactly what you said, Emil, and we basically just we waited. We kept him immobile, didn't allow him to move because I didn't want his proximal phalanx to abrade up against that screw. So we just kept him immobilized, gave it a couple more weeks really to make sure it was stable and healed because it was still a little tender at 4 weeks. So I waited 6 weeks and then 2 more weeks, and then we pulled it out. And he did fine. He was a little annoyed because we had to go back and remove it. He was a little annoyed because he lost the index finger knuckle. And he reminds me of it every time I see him, but otherwise he did well, and he's back to riding his bike. And so sometimes less is more. So my point here is that as much as the enthusiasm grows for these intramedullary nails, we have to still be careful about the indications. And to Emil's point, these long oblique fractures, particularly when they're really distal like this, I think it may be pushing the envelope. May have gotten away with what Brett recommended, which is putting the screw in a little bit more on the ulnar side of the distal fragment. But and I have done that in other similar fractures, but this might be one in the future where I just pin it or just lag screw it or something like that. And this is basically from Paco del Pinal, where he talks about if you have a lengthened stable fracture like this, sometimes you could put a second one in as a blocking screw to help prevent against that. So that's an option as well.
Okay, so if you just stop sharing, I can finish the last few slides. So there we go. Okay. So basically, we saw all the complications, and it's a difficult, sometimes problem with stiffness. Generally, metacarpal fractures are diverse. We saw that. There's multiple options for treating them. There are opening reduction, with enclosed reduction, with pinning, with the screw. There's non-operative and operative discussions were very fruitful here. It's important to have a careful attention to the technique, whatever technique that we're using. And we have to be mindful of the stiffness that can come up. Malrotation can come up either from the surgery or from the injury, and then possibility of fixation failure, as we just saw. And then post-surgery and post-operative hand therapy is very important, and to reduce stiffness and regain of function is the key part. Just to follow up, this is this series of lectures in hand surgery webinar will continue. Next one is going to be on February 16. We have a special fireside chat webinar from AO North America Hand Education Committee with 3 cases that will be discussed. So stay tuned, answer your email when you get that so you can register and participate. And thank you very much for attending the course. Remember, you will get the evaluation within 24 hours, and keep an eye out for that so that you can get your CME credit. Thank you very much.
Thank you, everyone.